Hello, my name is Dr. Neil Iyengar. I'm a breast medical oncologist, co-director of the Breast Medical Oncology Program and director of Cancer Survivorship Services at the Winship Cancer Institute of Emory University. I'm joined today by Dr. Jhaveri and Dr. Makhlin, and I'm looking forward to the discussion that we'll have with regard to recent emerging data for HER2-positive metastatic breast cancer. I'm going to let my colleagues introduce themselves. We'll start with Dr. Jhaveri.
Thank you so much. It's a pleasure to be here today. I'm Komal Jhaveri. I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center. I'm the section head for the endocrine therapy research program, and I have dual appointment within our breast medicine and our early drug development services. Pleasure to be here with both of you today talking about new data in HER2-positive breast cancer.
Thank you. Dr. Makhlin.
I'm Igor Makhlin. I'm a breast medical oncologist at the University of Pennsylvania. I have an interest in HER2-positive metastatic breast cancer from a clinical trial perspective.
Wonderful. Well, let's start by talking about first-line treatment for metastatic HER2-positive breast cancer, and specifically, let's talk about history, starting with CLEOPATRA. Dr. Jhaveri, maybe you could set the scene for us and tell us a little bit about CLEOPATRA, the long-term follow-up, and how it has established the first-line standard of care and where you see some unmet needs.
Yeah, no, absolutely. I think it's been over a decade since our practice has changed. We were very excited to have anti-HER2 therapy in metastatic disease, and we started using trastuzumab with chemotherapy when we learned that adding anti-HER2 therapy and chemotherapy together definitely was better than chemo alone. And then came along CLEOPATRA, where taxanes with dual HER2 blockade, including trastuzumab and pertuzumab, really beat our, the standard of care prior to that, which was just trastuzumab alone with chemotherapy. And for a decade, I think that has been our standard of care, given the progression-free survival benefit that we saw, which was about 18 months. But then we also saw very mature, follow-up data with over, 50 months of overall survival that we've seen past 5 years, or at the 8-year follow-up mark, if you will. And so really that has been our practice. The trial did allow us to give chemotherapy with anti-HER2 blockade upfront. And we did that up to maximal response or toxicity. It lands up being 6 months just because of the neuropathy that happens with the taxanes. And I feel like it's harder for us to then, push beyond that, even if we wanted to for certain tumors to get more responses, because I think the neuropathy kind of catches up. But I think that also helps us then maintain the HP for many patients who might not require additional therapy. We stop at the 6-month mark, we continue the HP, and that's what CLEOPATRA did. And I think that has really changed how we had, been treating HER2-positive breast cancers. But now we have exciting newer data as well that has currently replaced or, shown us data that can replace this standard of care in the CLEOPATRA regimen, which is very exciting. So we'll talk about that very shortly, I think.
Absolutely. Well, that was a very nice summary, and I think, as you mentioned, for over a decade, we've been talking about the very high bar of CLEOPATRA, but certainly lots of room for improvement. And I think now we're seeing newer data, which suggests that the bar is adjusted. We'll get to that. But I want to go to Dr. Makhlin and ask you, in your experience treating your patients with the CLEOPATRA regimen, what do you see as the largest challenges? Dr. Jhaveri mentioned the AE profile, neuropathy, and so forth. But certainly there are other challenges, schedule and other issues. Could you highlight for us where you see CLEOPATRA in terms of its challenges and how that might identify areas for improvement?
Sure. So, I think we should start with the fact that CLEOPATRA mandated docetaxel as its taxane. And practice has evolved over the last decade. We've seen some studies confirm that we can substitute paclitaxel, which in some ways can be better tolerated, in other ways it can be a little bit harder. We do deal with issues with counts with docetaxel, managing the neutropenia and the fatigue that we can see, which can be quite significant with docetaxel. And then with paclitaxel, Dr. Jhaveri already discussed the neuropathy, I think, which is the main dose-limiting toxicity that we tend to see, especially when we're giving weekly paclitaxel. The reassuring thing here is that with CLEOPATRA paradigm, we know that we're stopping the chemotherapy at some point. It's time-limited chemotherapy, and fortunately for many folks who are able to avoid the neuropathy, they then move on to HP maintenance, and they can have excellent quality of life for years.
Absolutely, yeah, well said. Well, DESTINY-Breast09, very exciting data. Let's move to that. Dr. Jhaveri, tell us a little bit about DESTINY-Breast09, maybe summarize for us some of the findings in general and what struck you the most when you saw that data set.
Yeah, I mean, I think I can take a step back and talk about trastuzumab deruxtecan and antibody drug conjugates. I mean, I think, our very first HER2-directed antibody drug conjugate was TDM1 or adotrastuzumab emtansine, very exciting for solid tumors, with breast cancer being the first one where we saw positive data that really shaped our paradigm in the second-line metastatic setting. So we were using CLEOPATRA. We then started using TDM1. And then what we learned was that the next generation of antibody drug conjugates were even better. And trastuzumab deruxtecan surely, showed us that data, and we had head-to-head trial comparisons, including in the DB03 trial, where we saw that T-DXd was way more superior than TDM1 and kind of, moved up the ladder in the second-line metastatic setting. So it was very natural for us to pick this agent and think about it. Can we bring it even further earlier line? And can we utilize it in the first-line metastatic setting with the idea that maybe using up our best therapies really upfront might have a larger impact, not only on progression-free survival, but also overall survival. And so that set the stage for DB09, where we tried to say, hey, can we use T-DXd? Could T-DXd alone replace THP? Could we think about T-DXd plus pertuzumab and then compare that to THP and see what the PFS looks like? And lo and behold, we did see that, despite our excitement and what we have been doing for a decade with THP, we did see a 40-month progression-free survival benefit with the combination of T-DXd with pertuzumab compared to 26 months, which we saw in the control arm, which is also better than what we have seen with CLEOPATRA. CLEOPATRA gave us 18 months, and it potentially could be because in CLEOPATRA, patients were not allowed during the maintenance phase of HP to get endocrine therapy, even though they had HR-positive tumors, which was approximately 50% of the patient population. We do that in practice, but the trial necessarily did not do that. 40% on the DB09 study did have endocrine therapy concurrently in the control arm, and maybe that's why one could explain potentially a longer PFS benefit in the control arm with 26 months, but 40 months, unprecedented, including 15% complete responses, which is really, really impactful, I think. So great data. I think it's nice to see this data. Certainly differences in that here we're doing T-DXd plus P until progression or toxicity. It's not like we're just doing an induction therapy the way we did with CLEOPATRA and then maintenance. We are giving this therapy the way we did in DB03. I think outside of the first-line setting, because of CLEOPATRA, in any subtype of breast cancer, we don't necessarily think about induction. We treat for progression and toxicity. So I think we have kind of just changed that in the first-line setting because of how CLEOPATRA gave us that, but because also of the quality of life that we talk about with the maintenance HP for some patients. So it's interesting with that. But I think the PFS is really impressive. It's good to see the data.
Absolutely, couldn't agree more. And that was a very nice summary. I think that the efficacy is really remarkable. And I want to come back to a point that you made with regard to tumor response. Because I think, as you pointed out, the complete response rate was really quite remarkable. And we're in an interesting place in the management of HER2-positive breast cancer where we're talking about more efficacious therapies, what some might consider to be an escalation of therapy, if you will. I actually consider it to be just a replacement with more efficacious therapies. But we're also talking about de-escalation, right? We've got trials that are looking at maintenance setting, trials that are looking at stopping HER2-directed therapy. In my mind, I tie this all together by saying we really want to use our most effective therapies up front to optimize disease control. And then when we can talk about what we do subsequently, and I think you highlighted that nicely in terms of tumor response. Dr. Makhlin, in terms of the efficacy with regard to T-DXd and pertuzumab, what are your thoughts about using this approach up front? Dr. Jhaveri mentioned the validation of T-DXd as monotherapy in the second-line setting and beyond, and the efficacy of T-DXd monotherapy in that setting. Should we be using T-DXd and pertuzumab up front, or should we save it for later? I certainly have some comments on that, but I would like to hear your thoughts.
Yeah, I mean, I think this is the question we're all asking, right? I think the bigger question is, does everybody need to be using T-DXd up front? And it's really tricky because we know that HER2-positive breast cancer is not a monolith. It is quite a heterogeneous disease, and we all have those patients that have been on HP maintenance for so many years, right? where they could have been spared indefinite chemotherapy in the frontline setting. On the other hand, we have those patients who are just not acting like your classic HER2-positive breast cancer. There just may be more heterogeneity in the biology. Patients with certain high-risk features like short time to recurrence from early stage, those that are not necessarily very HER2 addicted, the 2+ FISH amplified versus the 3+. There are challenging situations where it just doesn't feel, like it's enough to give Cleopatra. So at the very least, I think we have a really wonderful option here with T-DXd in those high-risk situations. But I do think it needs to be a more nuanced discussion with the patients.
Yeah, well said. I'm compelled by several years ago, we saw pooled analyses of the Destiny Breast trials that tried to identify predictors of better response to T-DXd, and more upfront usage of T-DXd was identified as a predictor of better long-term outcomes. And this, of course, was well before DB09 and our thinking about using it in the front line. And now we really have a prospective validation of that observational finding. So really using our best therapy up front, I think, as you point out, is an effective way to optimize the disease state before we move on to the subsequent lines of therapy. Dr. Jhaveri, do you agree with that? What are your thoughts about using T-DXd and Pertuz up front?
I think it's such an important point. I think, we're always grateful to have options for our patients, for a given patient in clinic. But overall, I think regardless of the subtype, I do think that using our best therapies up front might not be a bad idea. And the reason is, while we all practice, with all the data that we have, when we look at real-world data sets, the attrition rates after the first line are so real. In HER2-positive disease, where we have such great data, despite that, the attrition rate is 20 to 30%. And so if we were to hold off on giving these good drugs for the later line, we are having a third of the patients not receive them. So we're actually taking away an opportunity of a good drug by trying to save it for the next line. So I do think that one has to have that perspective in mind, and we've seen that in triple negative, where the attrition rate is higher at 50%. We've seen that in hormone receptor positive disease with up to 25% to 30% as well. So I do think that while we obviously don't want to harm our patients, we want to think about quality of life, but we also want to not forget that ultimately we want to give a drug which is actually going to make them live longer, hopefully, keep them progression-free for a longer period of time. And so I try and think about, why should I not give it rather than who should I give it to? And I think that's one perspective that we can keep in mind when all these data sets come by. But I think with newer data sets coming along, it's always good to have options.
I like that framing a lot. Essentially, an opt-out kind of approach. Who should I not be giving this to?
Yeah.
Let me push you a little on that, because one of the things we often think about when we see new data sets is, how do we apply this to our patient population?
Yes.
So are there factors that would push you to use a T-DXd Pertuzumab approach in the first line, or factors that would push you not to use this combination in the first line?
Yeah, certain factors that would definitely push me to use it would be like, a short recurrence from their, adjuvant treatments, where they received an HP-based approach, if you will, or they received chemotherapy and they still have recurrences. I think you want to reach out to an antibody-drug conjugate, an impressive one at that, where you've seen wonderful waterfall plots and wonderful progression-free survivals. So I would definitely want to consider for that. Another thing that we have learned also in HER2-positive disease is a third of HER2-positive disease also harbor the PIK3CA mutations. And when we have looked at analyses by PIK3CA mutations with Cleopatra, we've seen that those patients do poorly. It is an independent poor prognostic factor. And that was one of the stratification factors actually in the DB09 study as well. And there we did not see a difference in benefit, regardless of having the mutation or not. Yes. We've seen similar kind of analyses even with DB04 in HER2-low breast cancers, where PIK3CA mutation status did not matter. So I feel like if I know upfront for a patient that there is a PIK3CA mutation, there also I feel like I really want to give T-DXd over THP, where I might potentially lose that benefit. And the third one, I feel like it's rarer in HER2-positive, to see brain metastases really upfront in the first or second line, but it's still seen, it's still present. In fact, when we think about even the Catherine data, where we utilize TDM1 in the early stage residual disease setting, the first site of recurrence that we think about had CNS recurrences as well. So it is still something that we see in our patients. And we have such robust data from DESTINY-Breast12 in treatment of brain metastases as well. And so I feel like those three, are definitively a way to think about, I should definitely offer T-DXd to these patients. Outside of that, like a lot of disease burden, a lot of visceral disease burden, or just tumor burden in general. I feel like because it works so quickly, because it works so effectively, I feel like I want to reach out to something where I can actually control the pace of the disease with a very efficacious drug. So I feel like these 4 scenarios in my mind are a no-brainer to think about, yes, I definitely want to try T-DXd, given the totality of the data that we have with this molecule.
Absolutely. Well said. Dr. Makhlin, any other factors that you think about for patient selection?
I mean, I fully agree with Dr. Jhaveri and all of his factors. Those are what I'm thinking about as well. And then the only other one that comes to mind is, again, if it's somebody 3+ versus 2+ FISH amplified, especially if it's sort of a borderline call, that's a patient who I don't believe is as HER2 addicted, and we know response rates to standard anti-HER2 therapy is lower, both in the early stage and metastatic disease. So using something like an ADC like T-DXd covers your bases there.
That's a fair point and good point, and also alluding to the activity in HER2 low disease as well. But outside of the scope of today's conversation, so we'll stick with HER2 amplified disease, and I want to turn a little bit to the toxicity profile, adverse effects. We know that CLEOPATRA certainly is associated with AEs. We've talked about the neuropathy. Let's talk about in DB09 what we saw. And Dr. Makhlin, I'll turn to you for this. Walk us through a little bit what you anticipate in terms of adverse effects related to trastuzumab deruxtecan, the combination of T-DXd with pertuzumab, and any pearls that you may have for managing some of those toxicities.
Sure. And so I'll just start by saying that, reassuringly, we didn't see any new safety signals from frontline T-DXd. As expected, we already have, much experience with the drug since 2019. The way that I talk about this with patients is we need to talk about the side effects that we can expect that are more common and very manageable. And then we need to talk about the side effect that we all know should be burned into their brains as to when they need to call us in the middle of the night, right? The pneumonitis. So the more common day-to-day side effects I find can be very manageable. Fatigue and nausea are the 2 main ones that, at least in my clinic, I experience with patients. And for fatigue, I talk to my patients about lifestyle modifications. Exercise has been tested in the metastatic setting to combat chemo-associated fatigue. For nausea, we've learned over the years that this is a pretty emetogenic regimen. So being aggressive with pre-meds up front and then offering drugs like olanzapine at bedtime can be really helpful for managing the nausea. And, dose reduction can be very effective. Some patients their right dose is a dose level down from the standard, and that can be a major change, a game changer for the patient. For the pneumonitis, we know that roughly 10 to 12% of patients will develop any level of pneumonitis. Fortunately, most of that is low grade. But it's really, having that conversation with your patient. If you get short of breath, dry cough, fever, that's not a wait until the next infusion kind of discussion. That's I need to know right now kind of discussion, and instituting proper measures.
Absolutely. Well said. So being proactive. Dr. Jhaveri, are you using the 4-drug or 3-drug antiemetic prophylaxis? What is your approach to managing nausea?
Absolutely. It's been a game changer, actually. Trying to ensure that we use the 3-drug regimen, and on top of that can offer olanzapine as the 4th drug has really, really helped manage nausea in clinic, which I agree is the most frequent toxicity that we face actually with T-DXd. And while we worry about ILD pneumonitis, thankfully it's a little lower, but of course the vigilance has to be higher given what it could do in terms of outcomes, including fatal outcomes that can happen. But I think nausea management is really, really critical because that's your day-to-day toxicity, and it's a modifiable or a preventable or a toxicity that you could provide supportive care for. So I think making sure that our patients are taking it and making sure that they're reporting it back to us so we can do something about it. Fatigue is a very interesting toxicity, and I completely agree that you can see that with T-DXd as well. But I also feel like we as doctors, as our clinical care teams, need to probably probe into the fatigue a little bit more, which we don't necessarily do a good job at necessarily all the time. But it is subjective in some patients, right? And we need to get a sense of what is the level of fatigue that they're referring to. Is it really impacting their activities of daily living? Is it something that they're facing, but they're able to continue to do their, daily livings? And that can have an impact on how we want to modify the dose for a given patient in clinic. So that is something that I think we can do a better job at assessing this otherwise subjective toxicity, and we really want to do a better job at that. I think one thing I'll also add is alopecia. And when we had our late-line trials with T-DXd, certainly the alopecia rates reported were much higher. And so while I'm starting a patient on T-DXd, I certainly talk about alopecia all the time, but I'm sure we all have appreciated the fact that fewer patients actually land up having higher grade alopecia, and most people actually land up keeping their hair. And so I probably scare them a lot more than what actually I see in clinic, which is not a bad thing. I'd rather do that than not. And then some patients always ask about scalp cooling, and we're still trying to understand. I mean, these are longer half-lives. These are, antibody drug conjugates, which are different than our other agents. But if a patient is wishing to do that and wants to try that, we have trials ongoing addressing the question, but I don't say no. I just make sure that they understand we don't know if they are keeping their hair because of the scalp cooling or because they would have otherwise never lost it anyway. So I think I've kind of kept that approach in clinic for alopecia, and that has helped. And in addition, for the patient education for grade 2 ILD pneumonitis, which is reporting cough, which is very, very important to discontinue therapy, I think it's also our vigilance of looking at scans more carefully and reports more carefully, because it's the asymptomatic grade 1 ILD pneumonitis, which we can easily tackle in terms of holding drug, giving a short course of steroids, and maybe rechallenging. We've seen some rechallenge data as well. And keeping a patient on therapy, especially if they're benefiting really, really well. So we as a community have gotten a lot more vigilant with this, reviewing this, because we see pneumonitis with PI3K mTOR inhibitors. We see pneumonitis a little bit with CDK4/6 inhibitors. And certainly we want to keep an eye because of what we've seen with T-DXd and other trials. So it's about 12% is what we're seeing, 10 to 12%, and we want to continue to be vigilant about that.
Absolutely. Well, that was a really phenomenal summary of the AEs and management thereof. What I'm hearing is be proactive. For nausea, use the 3 or 4 drug regimen for prophylaxis. For fatigue, as you both have said, we know that we need to be multifactorial about this. Make sure that their hemoglobin is optimized. Make sure that there are not other factors, psychotropic factors, that might be contributing. We have the preferable effect trial in the metastatic setting, which showed the benefit of exercise in terms of improving patient-reported fatigue, and then certainly dose reductions when you need them. Screening for ILD, I'm reassured by every time we see new data from a more contemporary Destiny Breast trial, the ILD rates are either stable or even better, because as I think you've mentioned, we've gotten better as a community in terms of identifying and managing potential pneumonitis as well. So it sounds very manageable. How do we talk about this with our patients? Maybe I'll start with Dr. Makhlin. When you're talking to your patients, how do you frame the risk-benefit profile and your recommendation for, let's say, T-DXd Pertuzumab when you're counseling a patient?
I mean, I think it depends on it's situation dependent. So you sort of weigh the risk of the drug, the perceived or the expected benefit, and what are the alternative options, right? If the patient has very low burden disease, if they're de novo stage 4, if they're HER2 3+, all of these things together, no known brain metastases, maybe a little bit lower performance status, right? They may do really well with CLEOPATRA-style regimen, especially if they're ER positive, and we haven't talked about patina yet, but that's obviously another paradigm for first-line therapy. I mean, so there, the toxicity of T-DXd given indefinitely may not be as palatable. On the other hand, patients who, as a more typical HER2 positive patient, which has visceral disease at diagnosis, good performance status. And although I should say I've certainly treated many older patients into their 70s and early 80s with T-DXd, and they're doing well. So I don't want to discount that. But in any case, we're willing to take some of the more potential toxicities, fatigue, and nausea, and the pneumonitis, because we need to get that response, and we want to give them the best shot at having the longest PFS. I think it's always a balance and a discussion with the patient.
Yeah, absolutely. I like that framing of let's look at alternative therapies, but certainly let's look at the efficacy in the setting of the AEs. And given all the management strategies we've just reviewed, it certainly is a manageable approach. I want to get back to the conversation that we were having about tumor response and first-line use, and follow up on your comment about patina. We've certainly seen emerging data about maintenance strategies after a THP or CLEOPATRA approach. We've seen the patina data in terms of hormone receptor positive disease and the addition of palbociclib and endocrine therapy to HER2-directed therapy after you drop the taxane. And now we've seen HER2 Climbo-5 with tucatinib in the maintenance setting. That being said, I think it begs the question of what kind of response are we striving for with the induction part of the treatment approach, and where do we fit in all of these new data sets in terms of selecting the approach for our patient? This is a difficult question to answer, but I'll start with Dr. Jhaveri and ask you, how do you contextualize DESTINY-Breast09 in the setting of the emerging maintenance strategies as well?
Yeah, no, I think those are fantastic questions, very relevant, especially because our clinical practices have been driven by those approaches in the past decade, right? I mean, our patients have gotten used to getting induction-based chemotherapy with taxane HP, and then maintenance therapy with HP with or without endocrine therapy. And to build on top of that, we recently heard data from the PATINA trial, which showed that not only getting endocrine therapy, but adding a CDK4/6 inhibitor in hormone receptor positive, HER2 positive breast cancer really yielded a very attractive median progression-free survival of 44 months. What was also striking between the PATINA data set and the DB09 data set is how well the control arm did. And they were kind of comparable to me in both arms, and both of them did better than our CLEOPATRA data set with THP, where the median PFS is 18 months. But in THP PATINA, or induction THP and then maintenance endocrine therapy AHP, versus DB09, where they did THP and then could have gotten endocrine therapy, and 40% did in the control arm get endocrine therapy in DB09. We're seeing 26 to 28 months as well. So I think it's very reasonable to think about that's a reasonable approach for trying a maintenance strategy for a hormone receptor positive breast cancer. And then we also heard the HER2 CLIMB data with tucatinib, although there the control arm did quite worse relatively. We saw 16 months, and in the HR negative cohort, which was 50% of the patient population, was only 12 months. So I'm still intrigued by why did that do poorly, and why, despite having 70% de novo metastatic breast cancer, did we not see what we saw with CLEOPATRA even, let alone PATINA and DB09. But to your point about maintenance strategies, I think we certainly want to think about how do we optimize efficacy, how do we optimize quality of life, and PATINA builds on that, where we can give an upfront strategy. We used the same induction that we did with taxane HP, and then we did maintenance with CDK4/6 endocrine therapy in HP. The other way to also think about it is, can we use drugs where we can push the boundaries for responses? And those responses can be so durable such that we then impact progression-free survival and impact overall survival. So 70% of the DB09 patient population was progression-free at 24 months. And the duration of response in the 15% complete responders and the 70% partial responders was 39 months. So could we also think about a strategy instead of an arbitrary 6 months cutoff, which was really driven by neuropathy with taxanes?
Yes.
Could we think about a strategy where maybe we strive for maximal response with a strategy that is giving you good complete responses, good durability of response, and would that potentially lead to cure, may I use the word, or at least longer-term PFSs and OS? And on top of that, then build endocrine therapy or a CDK4/6 for our HR positive, triple positive. So say treat with upfront T-DXd until maximal response, and then throw in some maintenance for our triple positive patients. And will that beat even the 44 months we saw with Patina and the 40 months we saw in DB09 and make a bigger dent in the first line setting? And that's what we are eventually striving for. We're striking for that balance where we can really push the envelope for survival while maintaining the quality of life. So there are strategies like that even in the Translational Breast Cancer Research Consortium. There are studies which are looking at a kitchen sink approach where we give all drugs that have worked and given survival benefit. But the idea there is also, can we give a little bit of everything and then give them a break, because that might still lead to more cures and more survival benefits. So I think that's what we are really, truly trying to do. And I think we're getting kind of blurred with this whole induction because that's what we were doing for 10 years.
Right. Yeah, very well said. I mean, I think for me, it comes down to what therapeutic approach is going to give us the best probability of achieving disease optimization before we switch to a maintenance approach. But you're right that we need to validate these approaches and we need data looking at these questions. So it's really exciting times as the field evolves. I want to shift and talk about subsequent therapies after we use T-DXd Pertuzumab in the first line, let's say. And I think a common concern that we hear is, well, what do we do next after we've used T-DXdP? And I think this gets back to what we've been discussing, and that is it does make sense both biologically and in terms of patient presentation to give your best therapies up front and optimize up front so that you're proactive rather than chasing the disease. But Dr. Makhlin, what are your thoughts and how do you counsel colleagues who are concerned about how we sequence therapies after T-DXdP?
Yeah, I mean, I think, I can understand some sort of trepidation about thinking, because we know T-DXd is so effective, it's such a blockbuster treatment, that when somebody progresses on T-DXd, the sort of gut reaction is, oh my goodness, they're not going to respond to anything now. But I haven't actually found that to be true in clinic, and of course that sort of understanding comes from our experience with T-DXd in later line, which is how we started using the drug when patients had already had exposure to taxane, they've already had exposure to T-DM1, and probably had exposure to dacatinib. But the further up we move it into the first line, now we have all of those other treatment options still at our disposal. And because the chemotherapy is a different class, we're giving we're exposing the cancer to a different mechanism of action. So anecdotally in my own clinic, I've had patients who have gone back into a complete response with T-DM1 after T-DXd, and I'm not that surprised because it's a completely different mechanism of action. So at that point, it's really understanding what is the current performance status of the patient, what are their current comorbidities, and what toxicities have they experienced thus far, and do they have brain mets or do they not, right? Dacatinib versus not, and then making the best decision that makes the most sense for them.
Great. Dr. Jhaveri, are you following a similar paradigm in terms of how you sequence therapies? What are you doing after T-DXdP?
Yeah, I mean, technically, it's a little bit of a data-free zone in terms of knowing an optimal strategy or an optimal agent that we should definitely be using. I think it's not a one-size-fits-all approach even here, which is true for breast cancer overall, I think. But I agree with Dr. Makhlin when he said, if I have a patient who's had progression on T-DXd, but I'm really worried about brain metastases and CNS progression, I'm reaching out more for, say, a HER2 regimen, which is what I did after DB03 as well. If I had used up second-line T-DXd and I still was struggling with that, or even if it was not CNS progression, I was using HER2. But here, if I use it up front, I feel like I also have taxanes to rely on, and I think they are a distinct mechanism of action. It's a completely different way, a distinct payload from T-DXd, and I'm able to use that as an approach as well. Certainly T-DM1 is something we can use as well, but I think I am more leaning towards a taxane or a HER2-based regimen first, and then thinking about T-DM1 after, if I'm thinking about utilizing T-DXd and Pertuzumab up front.
Great. Yes, I think we're fortunate to be in a space where there are a lot of new therapies in the pipeline as well. And so I think the landscape continues to evolve. And But I do want to go back to a point that I think we all made, and that is that we know that it is helpful to our patients to optimize disease and strive for the best response up front. So really doing that in the first-line setting. Well, I want to thank Dr. Makhlin and Dr. Jhaveri for this really enlightening conversation regarding DESTINY-Breast09 and really the general treatment landscape in HER2-positive metastatic breast cancer. Thank you for your insightful comments, and thank you for listening.
Thank you.
Thank you.